Thank you, Tom. I appreciate being invited to this meeting. I think the topic is very timely and very important to discuss. I am a professor of medicine at Duke University, and as Tom mentioned, I lead studies around family health history and better understanding systematic risk assessments for individuals to inform their health. So this talk is going to be a little bit of background about the value of family health history, some of the results of the studies that we've done to better understand the context, as well as the impact of doing a systematic risk assessments. The next slide, please. So conflicts of interest. I'm not a consultant for anybody, but I did start a company to help commercialize the software program that we use in our research studies so that people outside of the research studies could use it. Next slide. So family health history, it is nominally the first genetic test, and this idea was first espoused by Francis Collins, but it essentially gives you information about your inherited risks. It also reflects shared environments of families. So it can be more comprehensive than just genetics. And sometimes those two interact, such as smoking and lung cancer. Genetic risk would lead to a much higher risk of developing lung cancer in the future. But it does only impart information about risk. So family history is never diagnostic. Genetic testing on occasion is diagnostic, but a lot of the genetic testing that we're going to be talking about are about risk. So they're in healthy people trying to identify the likelihood of developing a condition. And then it can sometimes be more informative, but also more confusing because of the shared environment and shared genetics component than just genetic testing is. So we'll talk a little bit about that. Next slide. So in terms of shared environment, this could be the physical space. So lead-based paint, asbestos in the walls, living in the home with a heavy smoker. It could also be the community structure. So safety, the ability to go out and exercise or find high quality food nearby. Next slide. Or it can be a family culture, such as we don't exercise, we just come home and watch TV, or we eat foods that are typical in the South where I live, which is heavily fried, lots of butter, every vegetable has to be covered in cheese sauce. Things like that also lead to disease risks that aren't inherited. Next slide. So risk assessment, it can improve both a population health as well as an individual health. So it's applied to an entire population. It can lead to bucketing groups of people in that population to different types of strategies for managing that risk. But it also is critically important for an individual in terms of defining what they should do. So by forecasting the disease risk in that person, we're able to provide targeted prevention or screening strategies. And these are different than what we currently use sort of as population level guidelines. So right now, colonoscopies are recommended at age 50. Actually, they've just changed it to 45, but we won't talk about that. So typically age 50 for everybody, regardless of your family history or your other types of risks. So those are good, very good. They've been very effective, but they aren't good enough in terms of narrowing down your individual risk and what's the best thing for you. So now we have these very large number of preventive guidelines that incorporate risk level into them. So an example of this is typical population screening for women is mammography starting at age 50. But if you have a breast cancer risk that's greater than 20% in your lifetime, then you actually should be getting MRIs, so breast MRIs and mammograms starting at age 25. So it's very different than starting a mammogram at age 50. But we have to know that you have a breast cancer risk of greater than 20% in your lifetime. And the only way that's going to happen is if we do a risk assessment when you're young. European guidelines for cardiovascular risk. So Framingham does not include family history. It did in one iteration many, many years ago, but they took it out. So the current ASCVD Framingham risk for a cardiac event in the next 10 years, it does not include a family history of cardiovascular disease. So the Europeans and the Canadians said, well, the family history risk is pretty significant. So we're going to multiply the Framingham score by 2.5 if you have a first degree relative with early onset coronary artery disease. That's a pretty significant increase in risk, 2.5-fold. So for colon cancer, routine colonoscopy at age 50, as I mentioned. But if you have a family history of colon cancer, then that actually could be a much earlier start age. It depends on who the relative is and at what age that they had their colon cancer. And now, because we take pellets out when we do colonoscopies, an adenoma on a colonoscopy is an equivalent for colon cancer in these guidelines. So again, you could be starting at age 40, age 30, depending on your family history. And so that as these get, as more and more of these guidelines get adapted to incorporating these risk strategies into them, more and more people are going to meet criteria for non-population-based screening. And we'll talk a little bit about how many people that is, but it's definitely a growing proportion of the population. And all of the hereditary syndrome genetic testing guidelines currently rely on family history. And again, this is for risk assessment. So these people are healthy. They don't have a disease. If you have a disease, then that's a very different set of guidelines. Or if you have symptoms and we're trying to figure out what's causing those symptoms, that's also different. But screening people for hereditary breast and ovarian cancer syndrome or Lynch syndrome or Cowden syndrome, all of these have different criteria for what the family history looks like, but it's all based on family history. It's who the relative was, what the disease was, what the age of onset was. So in order to do this, we need to know family history. And in addition, even cascade screening. So cascade screening is if you have a first degree relative with a genetic condition, then you should get tested specifically for that mutation, but you need to know you have the family history of that condition and what the mutation is. So next slide. All right, so we did and this is from a very small study we did very early on, where we looked at just a handful of conditions. So hereditary syndrome risk, which was primarily hereditary breast and ovarian cancer syndrome, Lynch syndrome, and Cowden. And in a primary care population in a large health system in North Carolina, we recruited about 1,180 some participants from the primary care clinics. They completed the family history risk assessment, and then we looked at how many people met criteria for these different types of interventions that would change how their preventative care or surveillance was being performed. And 26% of them actually met criteria for some sort of hereditary syndrome risk and should have seen a genetic counselor to discuss that risk and whether testing was appropriate for them. Small percentage, a little less than 1%, met criteria for a breast MRI starting at age 25, and 5% for a medication to prevent breast cancer. The larger group was those who should start a colonoscopy screening earlier or have it more frequently. So a normal colonoscopy on your first screening, normally you would get a 10-year follow-up. In these cases, based on the family history, even if it's normal, you should get screening every 5 years. So that's a more frequent colonoscopy, or you should start early. If you combine those two groups, that's almost 20% of the population in the study. And then ovarian cancer risk, low 1%, and thrombosis was about 5%. So looking at this, we can see that this is a primary care population. We didn't select anybody. We just offered it to everybody who was a patient in those clinics. We had a pretty good uptake. And this is a fairly large percentage of the population that is meeting something different than what normal screening would be. So this kind of started my whole research career in terms of trying to figure out like how big are these populations really, and how we can help people identify that risk and get the care that they need. So next slide. So I'm going to talk here a little bit about the relationship of family history to the genetics. So if you want to think about this as a 2x2 table, where you have a family history that suggests you're at increased risk for some type of disease, or you don't. And you could have a genetic test where the results of that test suggest that you're at increased risk for a certain condition or not. And when you have a family history for a certain condition and you get a genetic test for that condition and both say you're at increased risk, that's where they're concordant. And then same thing, if the family history doesn't suggest an increased risk and the genetic testing doesn't increase increased risk, then they're also concordant. So in those concordant groups, family history is your driver of who should have genetic testing, because family history is relatively easy to get compared to a genetic test, and much less expensive. So in those groups, you can kind of be confident that the family history is going to reflect the care that the participant needs, whether to get a genetic test or not. In the discordant groups, though, there are people who have a family history that's not suggestive of an increased risk, but when they get genetic testing, they actually do have a pathogenic variant. And in that case, the family history is not helpful, and you would want to do genetic testing first as your strategy for risk assessment. Or you could have a group where the family history suggests that there's an increased risk of disease, but when you do the genetic test, the genetic test doesn't identify a pathogenic variant. And in that case, the family history is going to define the individual's disease risk. So next slide. So examples of why these two discordant groups might exist are that when you have a strong family history, but you don't have an identified variant on a genetic test, it could be because the pathogenic mutation is there in the family, but we don't know about it yet, right? There's still a lot we don't know about genetics. They're constantly coming up with new variants, and there's lots to be done for many years. So there's quite a strong possibility that there's something there we just haven't identified yet. Also could be that the family has a pathogenic mutation in it, but the individual didn't inherit that, in which case they're protected from that family's increased disease risk, at least on the hereditary level. Or the risk could be driven by their shared environment and not by the genetics, or at least mostly by the environment and not by the genetics. In the other group, so your family history is negative, so you don't have an increased risk of disease based on your family history, but you do have a pathogenic variant on the genetic testing. So this could be an individual who they have a de novo mutation. So this is the first person in the family who's got this mutation, and in which case they certainly are at increased risk. The family history could be wrong. We're not going to go into that, but this is a big area of how do you get good family history? How do you get people to talk to each other about their family history? What happens if they don't know their family history? And obviously this is important in the adoptees. And then the last potential reason is that the penetrance of that mutation is quite low. And there are a lot of interactions with either protecting mutations or other environmental factors that are making it so that it's not showing up in the family. Next slide. So some clinical examples of discordance in the case of PALB2. So this was a relatively newer gene that has been discovered, and they've done some studies that looked at the relationship of the penetrance of the gene. So if you have a pathogenic mutation in PALB2, who gets breast cancer? And when they looked at that in relationship to family history, they saw that if there was no family history of breast cancer, the likelihood of developing breast cancer if you had a pathogenic mutation was about 33% by the time you were age 70. On the other hand, if you had 2 or more first-degree relatives with breast cancer, then that almost doubled the risk of having breast cancer by age 70. So that's a pretty significant impact, and can show how having a family history that is discordant in some ways is able to identify some protectors for that mutation. And another example is with the BRCA gene. So there have been studies now that looked at lots of studies now that have looked at people who wouldn't normally get BRCA gene testing. So most of the guidelines, like I said, around hereditary cancer testing say you have to have a family history that looks like this. Well, when they went out and started doing some of these screening studies where they just did sequencing on all comers or just specific genetic testing on all comers, they started to find that people were having mutations that were pathogenic in families that didn't have any type of history for that condition. So this particular study was basically done in California, where they offered every woman who walked down the street free BRCA genetic testing. This was around the time that Angelina Jolie was coming out about her condition, and it was a really big media hype for a long time. So they said, we're going to offer free genetic testing for this condition to anybody who wants it. And they had really high uptake of their offer. And what they found was that, one, a lot more people tested with a positive for a pathogenic mutation in the BRCA gene area than had been predicted based on the incidence of the hereditary breast and ovarian cancer syndrome to date. Much higher, so almost 4.5%. And then the other thing that they noted was that over half wouldn't have ever met the criteria based on their family history to get testing. So what does that mean for this group? Do they have a lower risk for having breast cancer if they have that pathogenic variant and they didn't have the family history? That they do, but there's a lot more for us to be able to understand here. So these are two really good examples of how discordance is important to understand. Next slide. So even when family history seems uninformative, that it's still exceptionally valuable, both clinically and for research. And we're really not going to, I'm not going to touch on the research aspects today. So next slide. So there's this other category in the genetics, which is the variant of undetermined significance. And family history also has an impact on how we think about these variants. So they're mutations that are in an area of a gene where it's likely that it has some type of effect, but we really haven't been able to associate it with one. But if you see a VUS in a gene that is associated with a specific increased risk for the condition that you're looking at, and you have a strong family history for that condition, then it helps to say that that VUS may actually more likely be pathogenic. And vice versa. If it is in this gene that could potentially cause an increased risk in that disease, but there's no family history, then it's maybe more likely that it's not pathogenic. Obviously, this isn't clear, that's why it's a VUS, but it does help pathologists in making their calls about whether a pathogenic whether variant is pathogenic or not pathogenic, or where it falls on the spectrum. Next slide. All right, so we're going to go back to some numbers. I gave you a few earlier on in that one study that we did in one health system. This is the only study that we've done to date where we have really good family histories and whole genome sequencing, where we can look at, in a healthy population, what the relationship is in the concordant and discordant groups. So it was 1,750 people in a study in Singapore, and it was a biobank study where they had to be healthy. And we looked at cancer only for the genetic and the family history relationship for this study. So what you can see is that the vast majority of people are concordant, right? So family history does a pretty good job of picking up who should get genetic testing. But there is this other group. So the family history that's negative, or the genetic testing is significant, is about 2%. And so these are the people that you would miss if you didn't have a genetics first strategy. And then there's about a threefold more of those people that fall in they have a family history, but they don't have a pathogenic variant on the genetic test. But all told, that's still 1/10 of the population. Next slide. And if we put all of that into context of what we found in our Greensboro study, which was that about 25 to 26% of the patients in a primary care clinic were found to have some increased risk for genetic condition based on their family history, you're starting to talk about some pretty high numbers. And we were actually able to show this in other studies where we were involved in broader populations. So in 4 healthcare systems across the US that were geographically and culturally diverse populations. So next slide. So for adoptees, there are a few specific things to think about it. And this kind of goes back to what Lisa Gibson was saying earlier, is that if there's a very strong likelihood that there might be something that warrants genetic testing, so if that disease risk might be high, then maybe they would that context would help them think through more about whether genetic testing is worthwhile or not if you don't have access to your family history. So in our studies, we actually, in the very first study that I presented, we actually excluded adoptees from the trial, and almost all studies that include family history do exclude adoptees, which is unfortunate. We did not exclude adoptees in our studies following that one. And so since then, we've had about 2% of the people who enroll in our studies do indicate that they're adopted. And typically, as you would expect, they have a lot less family history information that they enter into the system, but they usually have some, and it's typically from one side of the family. So they may say, you know, I know about my dad and I know about his brothers or his parents, but I don't know anything about mom's side. And they also tend to be much more grateful about the opportunity to understand the meaning of what they do know about their family. So, and again, excluding them seems extremely unfair when I think understanding the value of what they do know is even more important for this particular group of people. And clinically, I personally, because I believe how important family history is, I do collect a very extensive family history in all of my patients. A small number of them are adopted, but almost all of those know something about one side of their family as well. So, and oftentimes this is informative enough. So if you know that your mom had breast cancer at age 30, that's all you need to know. So you don't always need to know everything about everybody, but obviously the closer the relative, the more important the information. And as well as if someone died early, that's also incredibly important to know. So the quantity of data is less, but sometimes it's just knowing the right piece of information. Next slide. So that is it for my talk today. I have obviously lots more information I can share if people are interested, but I think this is a good foundation to start our discussions later today. So thank you for inviting me. I'm happy to take questions, I think, later.